A very good afternoon to everyone. I'm here to talk about radiotherapy in lung cancer. Where are we? In the next 10 minutes, I'll try to do justice to the topic. This is the outline. I'm going to talk about the role of radiation in early stage, locally advanced, and also a bit about RT and oligometastatic disease. This is the management overview, although this is a crowded slide. What I want to impress upon you is that radiation plays a pivotal role, not just in early stage, not just in stage 1, stage 2, but also in stage 3 and stage 4. So there is a role of RT everywhere in each stage of lung cancer. In early stage lung cancer, we heard from the previous speaker that surgery is the standard of care. However, there are risk groups within that subset of set of patients. You have low-risk surgical patients who can be treated with the standard of care, but you also have high-risk patients who might end up having a sublobar resection, or they might have an option of getting stereotactic body radiation. And then you have the frank medically inoperable patients where SBRT is the standard. So SBRT or stereotactic body radiation therapy is not something which is very new. It was reported as early as in the mid-90s, where clinical evidence showed its efficacy. But in lung cancer, we started seeing phase 1, phase 2 studies in the early 2000s. And since then, there has been a deluge of institutional and multi-institutional literature on SBRT. So initially, we had stereotactic body radiation, the role of it in medically inoperable patients, retrospective series which showed excellent local control of 85 to 90%. And also we had subsequently certain prospective series, although the numbers weren't so great, but the local control rates are very much comparable to the retrospective series. So this kind of established SBRT as the only treatment option that is possible in medically inoperable patients. But in operable lung cancer, it has always been a sore point, because as you heard from the previous speaker, surgeons are keen to operate on stage 1, stage 2 lung cancer, even if they don't have adequate lung function, because of certain inherent advantages that surgery provides in terms of histopathological analysis of the primary and the nodal disease, which gives you an opportunity to tailor your adjuvant therapy. The advantage with stereotactic body radiation being that it is non-invasive and the local control rates are as good as surgery is what our contention were. But we do not have any a very robust data on this, because there are very limited randomized controlled trials. And also when you compare surgery, you have a subset of patients who might turn node positive and receive adjuvant therapy. So it's not actually comparing apples to apples. And also post-radiation, there is always a challenge in comparing whether the patient has a true recurrence or if this is post-treatment changes. So short of a level 1 phase 3 randomized control trial, what we had, the closest are certain propensity match score analysis, where you have similar patients compared, although not in a randomized fashion. And there are many of these. And what they have shown over all these different 10 papers is that it is either SBRT and surgery are superior, are similar, and certain studies which say that surgery is better, and certain studies show that SBRT is better. So the search for the gold standard in operable stage 1 lung cancer continues. There were a couple of ambitious randomized trials which tried to address this issue. However, they were unable to accrue patients. The STARS and the ROSEL study across the Atlantic, they could not combine, they could only accrue 56 patients. So the STARS group in North America, they tried to expand their protocol, and they included 80 more patients in a prospective randomized prospective fashion. And then they compared with a similar subset of surgical patients, and they showed that probably surgery and SBRT are equivalent in terms of both short-term and long-term outcomes. So there are various ongoing trials, which probably in the next 4-5 years would give us some idea as to if there is really a clear winner in this scenario. However, SBRT is not without its problems. They early in the 2000s, we knew that patients who had the disease very close to the central airway, if you are little overzealous and treat them with high dose of radiation, you might end up having a lot of toxicity. So we kind of established this no-fly zone around the airway, where we felt that if the lesions are close to this, it is better to avoid giving radiation to these sites. However, over a period of time, we realized that it is not the location, but the dose that we need to tailor. And now with a risk-adapted strategy, we kind of divide these locations into central, ultracentral, and peripheral lesions, where in peripheral lesions, you can give a higher dose per fraction, while in central and ultracentral, you need to be a little more conservative with your treatment. However, the challenge in early stage patients who receive SBRT is that many of these patients eventually develop loco-regional and distant metastasis, making it very essential that these patients receive some form of adjuvant systemic therapy. There has been a lot of interest about adjuvant chemotherapy in these patients, although there is not much randomized data on this. We know that SBRT is also an immunomodulator in it, that it increases the immunogenicity and the antigenicity of the tumor, thereby acting as an in situ vaccine. So SBRT and immunotherapy is a very novel and attractive combination, and there are a lot of trials again which are ongoing, which over the next decade or so we will know which is the best combination, whether in the neoadjuvant setting or should they be given concurrently or should they be given in an adjuvant setting. Coming to stage 3 lung cancer, there are two major subclasses here, resectable and the unresectable ones, and radiation has a role to play in both these subset of patients. In resectable patients, although the standard of care is to do surgery followed by adjuvant therapy, or in some patients giving neoadjuvant chemotherapy or immunotherapy followed by surgery, there is also some interest in giving neoadjuvant chemo-RT because some studies showed that there is better mediastinal downstaging with giving radiation and chemotherapy in the neoadjuvant setting. However, this does not always convert to a survival benefit, and also it adds to the toxicity. So this is not really taken up as well. In resectable patients, the question is also whether should you consider these patients for surgery or should these patients undergo a definitive CTRT. There were two major trials, one of the intergroup 013 Albine's paper, which kind of showed us that compared to surgery and definitive CTRT, probably the survival is similar. But when you look at a subset of patients who undergo lobectomy, they definitely is an advantage of these surgical cohort over the definitive radiation patients. So in resectable patients, we have an option of doing surgery followed by adjuvant chemotherapy in patients who have T3, T4 or N0, N1 disease. And in slightly advanced disease patients, you do neoadjuvant treatment where chemo-RT can be an option, but not universally practiced. In unresectable NSCLC, we have gone through a lot of evolution over the past 4-5 decades, starting with the earliest paper in 1980, where radiation alone was used in a subset of patients who were not able to undergo surgery. And there, this seminal paper by Perez kind of established 60 gray as the standard when they compared 40 versus 50 versus 60 gray. Since then, there are many other host of studies which have established that compared to radiation alone, giving chemotherapy and radiation in combination improves survival. And similarly, giving sequential chemotherapy is probably inferior to giving concurrent chemo-RT in select patients. Then we kind of reached a place where we thought of escalating the doses. Although 60 gray was established in 1980s, 4 decades ago, we thought whether by increasing the dose, we would be able to improve outcomes. And unfortunately, this paper, the RTOG 617 Bradley group, showed that giving a higher dose actually worsened the outcomes. So what we learned in unresectable NSCLC is that CTRT is a standard of care. However, it is associated with slightly higher toxicity. Not all patients are actually candidate for CTRT. There are still a group of patients who would not be able to tolerate, especially the ones who have a large volume disease or elderly patients who would not be candidates for multimodality treatment, or patients with inadequate pulmonary function tests. In these patients, probably sequential CTRT is as close to the best treatment that is possible. And when you're doing CTRT, it is always better that you do a higher conformal image-guided treatment, because it can definitely reduce the cardiopulmonary toxicity. And we also learned that conventional way of escalating the doses is not actually associated with better control. So we have now looked at ways of doing unconventional dose escalation, and these are the various ways in which this could be obtained. The first and the most interesting of this is something called as an isotoxic dose escalation, wherein you kind of keep your normal tissue dose constraint at a pre-specified level, and you try to increase the dose to the target as much as possible till that threshold is reached. And many phase 1, phase 2 studies have evaluated this paradigm, and they've showed that it is safe and possibly associated with better outcomes. There's an ongoing phase 2, phase 3 study which would probably establish the value and role of this form of dose escalation. Also, PET-based boost, where conventionally we give a dose escalation to the entire tumor volume. Instead of doing that, if we can do a mid-treatment PET CT scan and boost only the dose to the volume which is remaining after the specific amount of radiation that has been associated with better local control and no increase in toxicity. We can also do stereotactic boost instead of doing the conventional way, and many studies have shown the feasibility and safety of doing this. And now we have proton therapy as the next big thing in radiation oncology, along with the other forms of hadron therapy. And many retrospective and some prospective studies have shown that it definitely improves the toxicity, and we don't know how much it would add on to the survival outcomes, although ongoing phase 3 randomized control trial is expected to answer the question. The other paradigm that we are exploring currently is doing something called as a functional lung sparing, wherein we can functionally evaluate the lung and then subsequently spare the part of lung which is actually working physiologically well, as opposed to a physiologically non-functional lung. Immunotherapy and radiation, we keep hearing about it. Whether it is really a match made in heaven or are we just in the honeymoon period, we really don't know. But we know that as of now, radiation-induced in situ vaccination kind of improves outcomes. And especially in unresectable NSCLC, the Pacific study has shown with its tremendous improvement in survival outcomes. We know that this is kind of established that as the standard of care. However, there are a lot of ongoing trials, not just in the adjuvant setting, but also in the neoadjuvant and concurrent along with radiation giving immunotherapy. We might have more ways to address the problem than in one. Also, we are looking at biomarkers, wherein although we have been currently treating all patients with CTRT, there may be a way of selecting certain patients by usage of the circulating free DNA and the circulating tumor DNA, and also by measuring the MRD, you could actually tailor their adjuvant therapy accordingly. This is one of my favorite slides because it shows that how we have actually evolved with our treatment over the past 4 or 5 decades. We started with a median overall survival of 10 months way back in 1980, and we now reached almost 50 months with the addition of concurrent radiation and chemotherapy along with adjuvant immunotherapy. Coming to the last segment, a bit about oligometastatic disease. There are various terms that are being used, oligoprogression, oligopersistent, oligometastasis. And there is a rationale of using local radiation in these patients because many of these patients predominantly fail locally. And by giving radiation to this local disease, we could probably check their growth of that local disease and prevent organ dysfunction and death subsequently. There are many phase 2 studies. These are 2 seminal papers by Puneet Iyengar and Daniel Gomes, which was published in the last 4 or 5 years, which established the role of local RT in a phase 2 manner. The Sabre Comet was the first phase 3 study, which again showed in a different group of patients, not just lung cancer, limited to lung cancer, that giving local RT in addition to systemic therapy improves overall survival and not just progression-free survival. However, we need to wait for phase 3 randomized controlled data before we start using this for every patient. And until then, we'll have to choose wisely our patients and the modality of treatment that we use. Some of the ways that we could actually choose these patients are by looking at their clinico-radiological profile, which might give us an inkling about their biological behavior. To summarize, the past of early stage and locally advanced and oligometastatic radiation, although radiation has been part of that treatment paradigm, we have expanded a bit in the present by the addition of multimodality treatment, where we have added chemotherapy, immunotherapy, and a combination of surgery in some patients. And the future looks bright with the increasing availability of different immunotherapy molecules. I'll leave you with this slide, and I'm happy to take any questions if there are.